Maron, Mike Gibson coming to you live from ACC 2024, and we're talking about a new drug, Ninerafaxstat. Is being used and tested here in patients with symptomatic, non-obstructive hypertrophic cardiomyopathy. Get all those words out, Marty. That's a doozy. So, talk to us about the drug. It's a new myotrope, how it works, and what you did.
Yeah, thanks, Mike. As you just alluded to, we're talking today about symptomatic non-obstructive HCM, which is a little different than what a lot of the efforts that have been going on recently in HCM, which have been focused on therapies for symptomatic obstructive HCM. For those patients, actually, there is now a lot of good therapeutic options to improve their heart failure symptoms. And therefore, just talking a second before we get into the drug about unmet need, the greatest unmet need for this disease, hypertrophic cardiomyopathy today, is really the symptomatic non-obstructive HCM, for which there are very few currently options therapeutically to help those patients that develop heart failure. And that is important because there's about 40 to 50% of the non-obstructive patients that are limited by symptoms that frustrate them, that are not alleviated by the current drugs. And so this effort, looking at a novel drug, Ninerafaxstat, which is a metabolic modulator or mitotrope, being applied or evaluated in that population to see if we can make some improvements in two things that matter most: how patients feel, improving how they feel, and of course, how they function, exercise capacity. And so that's the sort of 10,000 foot of the initiative here. The drug, Ninerafaxstat, as I said, it's a metabolic modulator, and here's the premise that's kind of at play here, is that we've known for a long time that in hypertrophic cardiomyopathy, it's a disease kind of energy depletion, that we've got a problem there because the levels of ATP and energy are less than in normal hearts, and that's really important because the main driver to symptom limitation, particularly in the non-obstructive HCM patients, is diastolic dysfunction. It's impaired relaxation, in particular with exertion, where that issue really creates a low cardiac output situation, limiting patients for that reason.
And
So,
Marty, is
yeah.
relaxation non-energy requiring, or does relaxation require some energy?
Yeah, thanks. I was just about to say it's actually very energy dependent. So very, very energy dependent process, myocardial relaxation. And if you've got an energy depleted sort of system like an HCM, that means that you've got really a very impaired myocardial relaxation, and that's what's driving the symptom limitation. And so this therapy is aimed at trying to improve or optimize myocardial energetics to, in fact, improve diastolic function, to ultimately improve the clinical issues of symptoms and exercise capacity.
HCM is such a cool disease. It just all makes such sense. So tell us what you found.
Yeah, so what we found is a phase 2 study in patients, again, with non-obstructive HCM, and what we found were two major observations. Was that the patients that were treated with drug Ninerafaxstat actually improved in terms of exercise capacity, measured objectively with cardiopulmonary exercise testing, with the variable of ventilatory efficiency. So the VE/VCO2 improved with treatment compared to placebo. And that's important because that submaximal cardiopulmonary exercise variable, is related to actually diastolic dysfunction, impaired relaxation. And so showing an improvement there is showing in a way, or really underscoring that the drug is doing something important pathophysiologically by improving diastolic function and allowing patients to exercise better as measured by VE/VCO2.
Mhm.
The other big area that we saw here too was improvement in those patients that were most limited at baseline. So this is a post hoc analysis of the cohort. So taking patients that were symptomatically limited at baseline, we define that by a KCCQ score of less than 80, or if they were NYHA class 3 at baseline, then the patients that were treated with Ninerafaxstat had a significant improvement in their health status compared to those with placebo. So patients felt better. And that's really important because that's sort of the real target group for therapy in non-obstructive HCM, of course, are those that are most symptomatic at baseline. And so given the idea that the drug seemed to be improving diastolic dysfunction by and that translated into patients feeling better as well.
Amazing. Well, you know, we're not only trying to add years to people's life, we're trying
Right.
to add life to those years. So I
That's right.
think quality of life is very important. Well, this is amazing. Any other areas where this drug might be used, like HFpEF in general?
Yeah, I think there's two areas actually. I think that, that two possibilities there. I think one is that, I think one direction that we may be going if we start first with just HCM, keep on starting first with HCM is that, that combination therapy, may be the way that we actually optimally treat patients. So what I mean by that is maybe a drug like this in combination with other approved drugs in the obstructive population would be even more advantageous than just single drug therapy, for example.
Hmm. Hmm.
So you could imagine maybe a day where a myosin inhibitor plus a metabolic modulator would be really helpful, as opposed to just one of those drugs. And then the second population would be potentially patients with heart failure with preserved ejection fraction, obviously a huge segment of the heart failure population, to which this drug, and I don't know about all of the HFpEF, but perhaps
Sure.
segments of the HFpEF population, this
Sure.
would those are the two areas.
Cool. Just amazing. Thanks
Yep.
for sharing this with us. And
Sure.
thanks to all of you for joining us here live from ACC 2024.
Thanks, Mike.